Welcome back to part 2 of cardiac pathology for clinical correlations. So first let's talk about congestive heart failure. Congestive heart failure is a broad term that really encompasses a lot of the pathologies we're going to talk about for the rest of this lecture. It occurs when the heart is unable to meet the metabolic demands of the body, either through failing as a pump or just pumping insufficient amounts of blood through the body. Now this can happen as a result of ischemia or some sort of hypertension. It can also happen if the heart is non-functional, such as valvular disease or infarctions. Now, cardiovascular disease tends to be one of the leading causes of death in the United States, and over 300,000 Americans will die from congestive heart failure. Depending on the pathology present, heart failure can manifest in one of 6 possible mechanisms. But what ultimately happens is the heart is going to try to overcome whatever obstacle is it experiencing. So, if there's some sort of hypertension or perhaps an infarct which is going to inhibit pumping, the heart's going to try to work around it, and it'll increase its cardiac work to attempt to increase its output. Now this is fine in the short term, and most of the time the heart can do this without any sort of issue and return back to normal. But a lot of these times, these conditions are long-standing, such as hypertension or an infarct in the muscles of the heart. So as a result, the heart is continually under stress, continually trying to increase output, and ultimately is going to continue to adapt in the form of either increased cardiac rate or heart rate, or increased hypertrophy, so the muscles are more prominent and able to help pump blood through the body. So for instance, if the heart is meeting resistance for systemic flow, the heart might increase its heart rate to get more blood in the body, or the muscles of the heart wall might become thicker so that it's more forcefully pushing blood through the body. Neither one of these conditions is really great, and ultimately can lead to something like arrhythmia or systolic or diastolic failure. The heart has several ways that it can adapt to potential pathology. First, it can increase heart rate with the addition of norepinephrine. Second, hypertrophy can be used to increase the contractular strength of the heart. And then finally, it can use the Frank-Starling mechanism, which the way this works is by dilating the heart chamber and essentially filling the heart with more blood. The response is kind of like a rubber band effect where more blood is going to theoretically be pushed into the body. Again, short-term effects, this is great, but long-term this can lead to cardiac dilation, which makes your heart non-functional. So think about the heart, the way it contracts, is if you recall from anatomy, it doesn't just pump singularly. It has a twisting notion, sort of like wringing out a towel of water. Let's take a look at the different types of heart failure. We'll start with the most common, which is left-sided heart failure. This is usually a result of some sort of systemic condition, such as hypertension, or anything that's happening after the blood would theoretically leave the left ventricle. We can additionally see this with things like ischemic changes in the ventricular wall, maybe due to an infarction, valvular disease, with things like the aortic and mitral valve being more commonly infected by diseases, as well as myocardial diseases. When we talk about left-sided heart failure, it means that the heart is not effectively pumping blood from the left side into the rest of the body. Now, this will ultimately lead to ischemic changes down the path of blood flow, but additionally it means that blood might be hanging back into the ventricles, which means blood isn't leaving the lungs effectively, which means we get pulmonary congestion. And what you can see here is something they called heart failure cells, where hemosiderin deposits are being absorbed by macrophages, which is basically a result of excess blood in the lung parenchyma. Now, if an individual had long-standing left-sided heart failure, they run the risk of running into right-sided heart failure, and it's usually an association of the left side that will ultimately give you right-sided failure. It is possible to see right-sided heart failure occur without left-sided heart failure in a condition called cor pulmoni. This is usually a result of some sort of pulmonary hypertension or pulmonary disease that immediately affects the right side of the heart without necessarily impacting the left side. However, even in cases of cor pulmoni, we still see the same issue of blood having issues getting back into the heart and seeing congestion in the venous system and organs such as the liver. With the understandings of the basics of congestive heart failure, let's take a look at some specific pathologies in the form of cardiomyopathies. Cardiomyopathy is a broad term that literally just means heart muscle disease. So any condition that affects the myocardium is considered a cardiomyopathy, and we have several categories we'll take a look at in just a moment. As such, the etiology of these conditions can range from viral infections to genetics to even environmental concerns and diet. However, recently they are starting to see genetic associations with this, so it's even more difficult to make designations between individual types of cardiomyopathies. As you can tell from the chart here, cardiomyopathies have a wide range of subcategories. So we're just going to focus on dilated, hypertrophic, and restrictive cardiomyopathies. It doesn't hurt to be mindful of the fact that right ventricular dysplasia is a type of cardiomyopathy because it does affect the myocardium. However, these three are really all I want you to focus on, and namely the distinguishing features of each. Personally, I really like this cartoon, particularly the restrictive cardiomyopathy, because he looks like he's having a lot of issues here. But these are some of the basic distinguishing factors between each of the three that can help you determine which one we're dealing with. First, we'll start with hypertrophic cardiomyopathy. As the name implies, we're looking at hypertrophy of the myocardium. The most commonly affected area is the left ventricle, which you can see here. Usually, this is a result of some sort of systemic increase in blood pressure, or potential volume overloads for excess blood flowing into the ventricles that the heart then needs to compensate to pump outward. One thing to note here is that increase in ventricular thickness ultimately means we're going to have a decrease in ventricular volume. So when blood starts to fill in the left ventricle during diastole, we're going to have less volume than we normally would. This means that when the blood does pump during systole, less blood is being pumped into the aortic system. Now the heart will eventually try to compensate by either more hypertrophy in order to pump more blood more often, an increased heart rate, or potential dilation, so we can see this with dilated cardiomyopathy as well. All these will eventually lead to heart failure if left unchecked. Next, let's talk about dilated cardiomyopathy. This is a progressive dilation of the ventricular space, and it's usually associated with heavy alcohol abuse. The heart is classified as having a globous and flappy shape, and usually has a more rounded appearance compared to a normal heart structure here. You don't get that nice apex formation, and instead you just have a rounded edge. Now when the heart is filling with blood, the ventricular space is increased, which means it can take on a lot more blood. However, the ventricular walls have not adapted it properly, which means that blood is not being effectively pumped into the system and is in some cases left in the ventricle. Now the heart might also try to compensate by increasing ventricular thickness, which will lead to hypertrophy. So dilated cardiomyopathy can ultimately lead to hypertrophic cardiomyopathy as well, like we saw in the case previously. So hopefully you can appreciate how interconnected these conditions are. As a result of the inability to pump blood, we see this as a systolic function because blood is not being effectively removed from the heart. And the third category to be mindful of is restrictive cardiomyopathy. This is usually a result of some sort of specific disease, and in this case we usually associate it with amyloidosis. However, you can also see restrictive cases in metastatic tumors as well as other metabolic accumulations such as iron. Because of these accumulations in the heart muscle, the heart now becomes firmer and is more difficult to contract than it normally was. What we'll typically see is a normal looking heart and ventricle system, but the myocardium will feel firm to touch. This means it has a less ability to expand and take on blood flow during diastole, resulting in a diastolic failure. With less blood in the ventricle, this ultimately means less blood is getting into the body, which means the heart might again try to compensate through hypertrophy or dilation. A subcategory worth mentioning is toxicity cardiomyopathy, which can be associated with drug use. There's actually a case of adriamycin, which is an anti-neoplastic drug used for disseminated neoplastic diseases. It turns out that this drug also targeted heart cells, which caused them to lose some of their myofibrils. This resulted in the heart having a much more rigid and firm shape, leading to inability of contraction. So now we'll take a look at ischemic heart disease and myocardial infarctions. Ischemic heart disease is any sort of condition that will lead to oxygen deprivation of the heart. Most cases of ischemia occur due to atherosclerotic plaque buildup, which we mentioned before, that's usually found in the coronary arteries. This does tend to be the leading cause of death in the United States, as we've seen so often, as cardiovascular disease tends to be the #1 killer in the US. The blockage isn't considered significant until we're looking at least 75% stenosis. Now, it isn't until the heart has experienced prolonged ischemia that it will undergo an infarction, which is a heart attack. So the myocardial infarction is usually a result of prolonged ischemic heart disease. Now, myocardial infarctions can theoretically occur at any age, but they tend to be more prevalent in older individuals. They tend to have a higher incidence in men. Women do seem to have protection against myocardial infarcts during their reproductive years. But as their estrogen levels taper off after menopause, they do have an increased risk of coronary artery disease and ischemic heart disease. Now, when looking at myocardial infarctions, it's important to be aware of the gross and microscopic changes that you'll see. Now, Robbins has a great table that you can refer to in understanding the gross features that are going to change as the infarct starts to heal over time, up to the 2-month period where you get complete scar formation. So you should be familiar with this table. Additionally, something worth noting, and particularly in the 0 to half an hour range, is we don't get any real gross changes in the infarct. So what that means is if a patient had died from myocardial infarction, we wouldn't see that infarct grossly, and if it's immediate, we wouldn't really even see significant microscopic changes. So as a result, when you start seeing some of the stuff that we're going to look at, it means that the infarct happened to a point where it can start to heal, and the patient was alive for some of this stuff to form. So let's take a look at some gross photos on these infarcts. So first, we have the 24-hour infarct, where you see this dark mottling appearance. Here you can see some congestion where in the infarct site. Compare that to the normal myocardium surrounding it. Within the first couple of days, we see this central yellow-tan core start to form, but we still get this dark mottling completely surrounding it. You usually see more prominent dark mottling compared to the core. As we get to the end of the first week, we see that that tan-yellow core becomes much more prominent in this infarcted site, and the borders become these thin hyperemic edges. When we get to about the 1-week-old infarct, now we can see that that yellow-tan core has become much more prominent to the point where even some of our hyperemic borders are starting to disappear. So you can see them a little bit here, but as we get to this infarct site over here, they start to kind of vanish. What's interesting is you can see that this infarct covers almost 50% of the myocardial wall for this ventricle. At about 2 weeks, that yellow core is completely replaced by this gray-yellow beginning of fibrotic tissue replacement. So you see a little bit of the central depression here as the scar continues to heal over time. But once we get to about the 2-month period, now we got a complete scar formation that looks like what we normally see in scarred tissue. It's got a very dense fibrotic appearance. Now, like I said before, this implies that the patient was alive for at least the 2 months in order to allow that scar to heal completely to look like this. Now, that's not to say that this scar won't have any long-term health effects. If you look at it, our myocardium has now become significantly more rigid in this region than it was previously. And if you think about what we talked about with restrictive cardiomyopathies, this has basically created its own restrictive cardiomyopathy because now the heart is no longer pliable and able to expand in this region as it would over here. So having multiple infarcts are eventually going to lead to the point where the heart is undergoing significant stress. It's going to have continuing failures with diastole and filling because it doesn't have the ability to expand anymore. And this is ultimately going to lead to arrhythmias. So even if an infarct completely healed like this, you're not out of the woodwork yet, and it's definitely something that has to be treated. Here's a cross-section where you can kind of look at multiple infarcts compared to each other. So first we have the acute hours-old infarct, where you start to see a couple of the dark mottling. Again, the image quality isn't amazing, but hopefully you can see the compare and contrast between a couple days, a couple hours, and a couple weeks. So in the couple days, we start to see that yellow-tan core take formation. This one looks like it's almost about a week old because we no longer have those hyperemic borders. And then we get over here to the white scar formation, so we're at least at 2 weeks, maybe a little bit longer. Now, if you look at this thing as a whole, you'll notice that at least 75% of our heart parenchyma has now been infarcted. So not only when these heal do we lose the ability of the elasticity of the ventricle in order to fill effectively, but if we refer back to our conduction system, our Purkinje fibers, which were normally running through this myocardium, have now been blocked. So ultimately what we'll see is there's going to be an inhibitance of cardiac conduction, and we'll no longer get synchronized conduction of the heart muscles because of these infarcted sites, depending on where they are. This is what ultimately leads to arrhythmia, which is an acute condition characterized by a sudden disturbance of cardiac conduction. So that about summarizes our myocardial infarctions and our cardiomyopathies. So let's go ahead and take a look at the third unit as we continue more with heart pathology.